Thanks a lot, students. Over to PRASHOB.
So hello, thank Dr. Arup for giving me this opportunity again. So we're talking on toric IOL calculations, no financial interest. Now why do we want to implant a toric IOL at all in the first place? It's because it's been found by many studies that roughly around 1/3 patients undergoing cataract surgeries have significant astigmatism of more than 1 diopters. About 20% have more than 1.5 and 8% have more than 2 diopters. Of course, toric monofocal IOLs gives a better uncorrected distance visual acuity, and when it comes to multifocal IOLs, they have very little tolerance for astigmatism. So it needs to be addressed using a toric IOL. The prerequisites for a toric IOL calculation are have been told by Dr. Arup before itself. I'm just going to repeat it. The ocular surface and the tear film are of paramount importance. And I would always suggest, if you have access to a topographer, even a Placido-based topographer, to do a topography before you plan on a toric IOL, rather than just a catarametry. Because the topographer gives you a better idea about irregular astigmatism, and it does not just tell you about meridians. And when you have irregular astigmatism, your planning kind of changes. That I'll explain later. And of course, axial length has to be accurately measured, preferably with an optical biometer. If not, a good ultrasound biometry with an immersion technique will also do. And for keratometry, we have several devices available nowadays with us. And if you have more than one device with you, I would suggest take readings from both the devices. And if you have only a single device, take multiple readings. There have been several advances in determining the corneal power, and there are various devices. This is not an exhaustive list. There are n number of devices which can measure the posterior corneal power and determine total corneal power. Some of them are the Galili, the dual Scheimpflug camera, the Cassini, it's a color LED topographer, and the total keratometry from the IOL Master 700. These are the main ones on which studies have been conducted, and they have shown to be reasonably reliable in predicting the total corneal power. And other considerations for toric IOL calculation are pre-existing astigmatism, your surgically induced astigmatism, and the presence or absence of irregular astigmatism. Pre-existing astigmatism, we of course get it from the keratometry. Surgically induced astigmatism, we are not that bothered about nowadays because Dr. Hill has provided us with the SII calculator, and it has been found that for most of our surgeries, sub 3 mm incisions, the value goes around between 0.8 and 1.4. Posterior corneal astigmatism was formerly considered insignificant, but now cataract surgery is a refractive surgery. And earlier, we used to have a number of patients who have an error of about 0.72 to 1 diopter. Nobody knew where it came from. It was thought to be caused by IOL tilt. But now we know that posterior corneal astigmatism is important, and it has an average about 0.3 diopters, and mostly doesn't change with age, unlike the anterior corneal astigmatism, and it goes in the against the rule direction. So if you do not consider it, it can lead to overcorrection of with the rule or undercorrection of the against the rule astigmatism. Now, there is an important question here whether we have a reliable enough instrument to accurately assess the posterior corneal astigmatism for toric IOL calculations. Now, this situation is significantly getting better every day, that we have better instruments to calculate posterior corneal power. However, all said and done, the regression formulae, such as the Baylor nomogram, the Abulafia-Koch formula, and the Barrett-Toric calculator, have consistently shown that they perform as well or even better than the instruments that measure the posterior corneal power, using nomograms that calculate the total corneal power from just the anterior keratometry. So this has been a battle between statistics and actual measurement of the corneal power. So far, statistics have been winning. The Baylor nomogram is a nomogram which you can obtain, and it usually calculates the toricity at the corneal plane using a Holley 2 formula. You should factor in your surgically induced astigmatism, apply the nomogram. It tends to leave some with the rule astigmatism. There is also the Abulafia-Koch formula available on the physical-toric calculator online. But this is the most popular and the easiest formula to calculate IOL power for toric IOLs that is available nowadays. It's a Barrett toric calculator available for free on the ACRS website. And it has more or less outperformed all other methods to measure posterior corneal astigmatism or matched it. It calculates the spherical power using the Barrett's universal 2, and there is also the option of entering the measured posterior corneal astigmatism using any of the instruments that I mentioned before. You can enter a measured PCA, or you can let the nomogram calculate the posterior corneal astigmatism by itself. These are the new kids on the block, the Kane formula. Kane formula has been found to have similar outcomes as the Barrett toric calculator. And it also has an optimization for keratoconus, which may be very important. However, I would strongly encourage to consider and think twice before implanting a toric IOL in keratoconus, only if it is a central cone and if it's a reasonably regular astigmatism, and if your manifest astigmatism and the keratometry are matching, only then go for the toric IOL in keratoconus. And don't go for toric IOLs in keratoconus if you think the patient will continue to wear RGP or scleral contact lenses after the surgery. Evotoric formula, that is the emmetropic verifying optical formula, is the latest one. It uses the thick lens modeling and theoretical prediction of the posterior corneal astigmatism, and its performance, according to some studies, has been found to be similar or in accuracy as the Barrett toric calculator. Now, surgical induced astigmatism was a big deal some time before. It is the change in power of both the change in power and the meridian of the astigmatism after the corneal incision. It depends on various factors. The corneal SIA depends upon the incision location, size, architecture, radius, thickness, rigidity, the stretching of the incision as the folded IOL pass through it, the biological response of the cornea. Corneas with greater hysteresis have lesser SIA. Then there is also the lenticular SIA. There can be IOL tilt that can produce a surgically induced astigmatism. So to prevent that, you make sure you have enough coverage of the anterior capsular rim around the optic of the IOL. And depending on the AC depth, if the predicted AC depth is more or less than, if the actual AC depth is more or less than the predicted one, you can have a difference in not just the spherical path, but also the toricity. And remember that average SIA may not be the same as the SIA in the next case. However, there's very little that we can do about it. So the SIA has been shown by Dr. Hill to be not changed too much. And the vector analysis of SIA has been a game changer. And according to the centroid values, the mean, it is a two-dimensional value of SIA for a series of patients. And it has been seen that for sub 3 mm incisions, it ranges from about 0.08 to 0.14. So if you don't bother to calculate SIA also, you can just key in as the value of 0.12 if you're doing a temporal clear corneal incision. Or you can calculate your own SIA by going to the website siacalculator.com. There are various image-guided systems, Verion, Callisto, IOL Compass, Zaldivar toric caliper. They help in reducing the parallax and transcription errors while you transfer data from one instrument to the other. There are a number of online tools. This is not an exhaustive list. There are various number of tools that you can use, apps and online tools using mobile phone photography. And there is also intraoperative barometry, which performs an aphakic and pseudophakic refraction on the go while you're operating. The ORA with Verify is the one that is popular. Holo Syntrop, I do not think is manufactured anymore. And it guides the surgeon, gives the direction in which the IOL has to be dialed during surgery to achieve emmetropia. Post-op analysis is important. See how your cases do and what has gone wrong and what can you do to make it better. Does it require an IOL exchange or is a simple IOL rotation enough? For that, astigmatismfix.com, recalculatortoric.com, and the Barrett's RX formula are useful. So to sum up, the keys to accurate toric IOL power prediction are accurate keratometry. You have to pay attention to the basics, the ocular surface, rule out irregular astigmatism, do a topography if possible, as much as possible. Make sure you're positioning the head properly while taking the keratometry. Take multiple readings, see if they are in agreement. use multiple instruments, and of course use modern formulae.